Hello, my name is Ryan Holleman. Today I'll be presenting the final requirement of the Applied Research Project for consideration of completion of the Doctorate of Athletic Training degree at A.T. Steele University. My project is entitled Sport-Related Concussion and Policy and Procedure for a NCAA Division I institution. This project was completed under the advisement of Dr. Valovich McLeod. I'd like to personally thank her for serving as the advisor on this project, and I would not have been able to complete it without her guidance and leadership. For some background on how this project came about, we first need to look at three very important items and their relationship between each other. Sport-related concussion continues to be a hot topic in today's landscape of collegiate athletics and in the media. Student-athlete health and welfare has moved to the forefront of the agenda for organizations such as the National Collegiate Athletic Association, and in a society that is quick to move on litigation, policy and procedure has become an extremely important part of risk management. For this project, we'll dive deeper into concussion in sport, specific to the patient population that participates in intercollegiate athletics. We'll look at policy and procedure in healthcare, as well as collegiate institutions. And finally, to tie it all together, we'll discuss the role that the NCAA plays. While concussion is a commonly referred to diagnosis for a sport-related head injury, there is no consensus definition for concussion. In fact, it's estimated that there are over 40 consensus-based definitions of concussion in the literature. Carney et al. Has identified the need to develop an evidence-based definition for concussion that can be used in a uniform manner across the clinical and the research settings. The NATA position statement defines concussion as a head injury eliciting clinical signs and symptoms and cellular changes to the brain secondary to direct or indirect force to the skull. The expert panel that attended the 5th International Conference on Concussion in Sport held in Berlin defined concussion as a traumatic brain injury secondary to biomechanical forces. The American Medical Society for Sports Medicine defines concussion as a disruption of brain function involving an intricate pathophysiologic process secondary to trauma. Commonalities among these definitions include injury to the brain and the presentation of signs, symptoms with a decrease in function. An accepted definition would potentially decrease confusion among other commonly referred to terms, enhance communication between patients and practitioners, and also bridge the gap between clinical practice and research. Looking at some epidemiology, the incidence of sport-related concussion at the collegiate level has been researched with much of the data coming from convenient samples, such as the NCAA Injury Surveillance Program. This brings into question the accuracy of epidemiological measures for this specific patient population group. Research from Bryan et al. Analyzed the youth population and estimates that 1.1 to 1.9 million sport-related concussions occur annually in children under the age of 18. When this data is translated to all ages, the estimated number of sport-related concussions is anywhere between 980,000 and 2.3 million each year. Another important background note on concussion is the increase in concussion rates over recent years. Shamo et al. Reported a significant increase in overall concussions and concussion rates between the 2005-06 and the 2014-15 seasons in high school athletes. It is hypothesized that an increase in traumatic brain injury awareness and the fact that legislation has been proposed or implemented in all 50 states and the District of Columbia has led to this increase in reporting. With that said, we can make a reasonable inference that this would also translate to the collegiate population. Policy and procedure in collegiate sports medicine affords healthcare providers a framework as well as detailed instructions in the operation of their department. When discussing policy and procedure, it's important to distinguish between the two terms as they are not synonymous. An accepted definition of policy is authoritative decisions and guidelines that direct human behavior towards specific goals. Procedure refers to the actual step-by-step instructions that are utilized to implement the policy. Policies and procedures are an important element in risk management and ensure compliance with current laws, rules, regulations, and best practices for our patients. The second Safety in Collegiate Football Summit resulted in inter-association consensus statements for 4 paramount safety issues in collegiate athletics. One of these 4 issues includes the diagnosis and management of sport-related concussion. The NCAA initially implemented legislation in April 2010 that required schools to have a concussion management plan on file. This plan required students to be removed from activity if they exhibit signs or symptoms of concussion, and also required them to receive education materials and sign a statement that they accept responsibility to report concussions to the medical staff. In January of 2015, this was taken a step further, and the concussion safety protocol review process was implemented for the Division I 5 conferences with autonomy. This is a requirement for schools in the ACC, Big 10, Big 12, Pac-12, and SEC conferences and requires their protocols be consistent with the diagnosis and management of sport-related concussion best practices interassociation consensus document. All other Division I schools outside of the commonly referred to Power 5 conferences have the option to submit their protocols for review on an annual basis. To ensure compliance with the best practices document, a concussion safety protocol checklist was developed to ensure schools meet all these requirements. Another of the 4 safety issues in college athletics that was addressed was independent medical care. Out of this document came the athletics healthcare administrator position. This person is responsible for being the administrative contact for healthcare on each campus. Their role in the concussion process is to submit the protocols to the NCAA. The NCAA has identified 4 guideline components of a concussion management plan, which includes education, pre-participation assessment, recognition and diagnosis of concussion, and post-concussion management. Ball et al. Determined that a majority of NCAA member institutions were compliant with a large portion of the mandated components. However, there was not 100% compliance across all schools and all divisions, which leaves room for improvement. To dive into some of the 4 identified components, 95% of schools admitted utilizing some form of baseline testing, but of those responses, only 23% conduct baseline on all of their athletes. Many schools reserve baseline testing only for their high-risk sports. While these stats are certainly helpful in understanding the gaps of what should be included in our policy, a larger gap exists in whether schools are actually following the protocols they submit and have on file. There's been minimal effort to research NCAA institutions and self-reported measures of compliance with concussion management. Ball et al. Found high compliance with institutions reporting their concussion management plan, and Buckley et al. Researched the NCAA Power 5 conference schools and found high compliance across the components of required submission areas. The previous mentioned studies, however, only study the compliance with submitting their policies to the NCAA. Future research needs to investigate the compliance of the concussion management plan in clinical practice. This knowledge gap led to the creation of this fishbone diagram. Here we identify 4 causes that lead to the effect of an inability to ensure compliance with institutional policy and procedure. The 4 areas include documentation, policy and procedure, stakeholders, and the setting. This diagram is specific to my institution, which is a California Bay Area-based Division I university that participates in the West Coast Conference. For our institution, documentation was a major player. Some causes identified under this heading included lack of concussion-specific documentation forms, no quality assurance process, and an access to an EMR which is web-based, meaning a barrier is having access to the internet. Policy and procedure was another component. Staff feedback unveiled a barrier of unclear language in the policy and procedure manual, as well as a lack of training or method to identify the effectiveness of any training that may have been delivered. A third component was the stakeholders. All identified stakeholders needed to have familiarity with the policies. For those outside of the sports medicine department, such as coaches or academic advisors, this was something they don't deal with on a daily basis, and their compliance and comfort level was greatly diminished in comparison to those housed in the sports medicine unit. It's also important to note that the physicians and athletic trainers utilize separate documentation systems, which creates a barrier in communication and complete medical records. The setting is also unique for athletic trainers. We work outside or in areas without internet access. This requires separate spaces and separate time to complete documentation. Now that a problem has been identified, an aim statement was created. The purpose of this quality improvement initiative is to create an objective measure and system to evaluate compliance with institutional concussion policy and procedure in an aim to improve the best practices of healthcare delivery and documentation. Once the aim statement was created, it was time to get to work. This led to the first Plan, Do, Study, Act cycle. In this cycle, the highlights included evaluating current policy and creating a form to analyze concussion cases with a pilot group. During PDSA Cycle 1, an instrument was created to help establish an objective measure of compliance with the concussion policy. The quality assurance checklist was created, and it was separated into 8 sections, which mirrors the components of the NCAA Concussion Safety Protocol checklist. This instrument is intended to be utilized upon discharge of patients to ensure that all components of the policy have been met. After utilizing the form on a small pilot group, a second PDSA cycle was implemented. Here, the form was refined, training began to take place, and data began to be collected. The second PDSA cycle led to the finalized quality assurance form, which can be seen here. Notice that the 8 sections mirror the sections of the concussion safety protocol checklist. Another important component of this form is that an evaluator who is not involved in the direct patient care completes the form and is able to review it with the primary athletic trainer that was involved in each patient's case. The primary method to complete this project included a retrospective review of the concussion data for cases that occurred during the 2017 calendar year. This provided a baseline of where compliance was at with the institutional policy. The results of this retrospective review are as follows. A total of 30 cases were reviewed. There were 28 total patients, meaning that 2 student athletes suffered multiple concussions. Of these 28 patients, 16 of them were male and 12 were female. In the upcoming slides, I'll provide highlights of the results from each section of the quality assurance checklist. As you can see here, preseason education and pre-participation assessment yielded very high compliance. It's important to note that while 100% of student athletes received education during the preseason, it's critical that as a profession we continue to investigate the methods of delivery for education to ensure that it is comprehended appropriately by our student athletes. Also note that while baseline testing was not 100%, it was due to an institutional policy that did not require all sports be administered a baseline test. This policy has since changed and been updated where students now receive baseline testing across all sports. In this section, we note that 83% of concussions occurred during sanctioned events that always met the criteria of having an athletic trainer present or available. Only 84% of the cases that occurred during sanctioned events were reported the same day by the athlete. Of the 21 cases reported the same day, 81% were immediately removed from play and 76% met the full evaluation criteria. It's important to note here that these numbers only reflect what was actually documented in the patient chart. There may have in fact been 100% compliance with immediate removal from play, however we don't know that because it was not documented in the chart. This confirms that documentation is a critical component in policy and procedure and risk management and will be a common theme throughout these results. Of the 21 cases that were immediately evaluated, 17 had documentation that the site EAP was followed. 1 case required referral to the emergency department. Only 24% of the cases included delivery of the home care instruction sheet. The return to play section is an area that had low compliance when it came to documenting the return to play as well as the symptom scores pre and post completion of each stage. This results from this section identified the area where the next PDSA cycle would take place. The final 2 sections are ones that yielded the same statistics for every case as they were reflective of institutional beliefs in independent medical care and in the athletics healthcare administrator signing and completing the submission of the concussion protocol. Section 7 was the most difficult to truly place an objective statistic on. Our institution does not compete in football, where limiting head trauma has been a priority as evidenced by rule changes on the number of practices in each day. It is difficult to objectively measure how each individual sport would truly reduce exposure to head trauma. Soccer and limiting headers immediately come to mind. However, without baseline data on the number of header exposures, it's difficult to quantify what reducing truly means. Following the review of these results, a 3rd PDSA cycle was implemented. As this project will be ongoing and extend far beyond the timeline of this degree program, this cycle is currently being implemented right now. It's scheduled to conclude at the end of June 2018. At that time, another need will be addressed and a 4th cycle will be implemented. As previously discussed, an area of concern that needed immediate attention was the return to play section. The highlights from the 3rd cycle include the addition of 2 new specific forms for documenting the return to play process. The first form seen here was created to ensure that each stage of the return to play process was defined and creates an avenue for the athletic trainer to document the completion of each stage. A space for the student athlete to acknowledge completion was also created as a checks and balances for the documentation process. The second form allows the athletic trainer to document symptoms before and after completing each stage of the return to play process. As the results indicated, none of the cases that were reviewed in 2017 documented symptoms for every single return to play stage. It is expected that compliance in the return to play area will increase significantly now that an avenue for documentation has been created. So what did we learn through this process? Personally, it was very difficult to follow the PDSA cycles and attack one problem at a time. Athletic trainers are fixers by nature, and we are driven by results. While it was tempting to try and address multiple sections that exhibited low compliance all at once, it was not the right strategy to play when completing this project. Medical records were a limitation during this process. As identified in the fishbone diagram, systems between the athletic trainer and physicians were different. Fortunately, the athletic trainers at our institution have access to the physician's EMR and can access their records. While it's not ideal to have records in multiple places, this will be another future project. Staff is a limitation in that we employ clinicians with varying levels of experience. For example, at our institution, we employ a range that includes first-year graduate assistants all the way to clinicians that have 20 plus years of experience in the professional and collegiate settings. Staff turnover also becomes an issue if you have to hire new positions. The education process then restarts. Time was a lesson and a limitation here. The patience required to complete PDSA cycles is challenging, but extremely important in order to yield valuable results. A lesson for me was the expectations going into the project. As the administrator and leader of a unit, it's humbling and challenging to see data that's not at 100% compliance. However, it's extremely rewarding to know that you're making changes in policy and procedure that ultimately lead to better healthcare and outcomes for the student athletes that we serve on a daily basis. Future aims were divided into two areas. First, NCAA member schools need to look at compliance and accountability with each of their respective schools' protocols. Not only will this improve patient outcomes, but it will ensure best practices in risk management. The third bullet here is an important point to consider, as there is discussion on whether a standardized protocol should be implemented across schools and all divisions. There are pros and cons to this, which are better left for a different time. Institutional aims include continuing to refine the concussion protocol in each section that yielded low compliance. This will be achieved through multiple PDSA cycles. Even those that had great results should continuously be evaluated, and this project creates an avenue to do just that. There is also the ability to use the framework of this project to evaluate other policies and procedures across the sports medicine department. It's important that information be disseminated and a spread plan be developed. There are plans to continue this project and ultimately set up to be presented at sports medicine conferences and to seek publication within a scientific journal or other sports medicine related publication sources. There may also be an opportunity to translate these results to other organizations in other settings, such as high school or professional sports. Please note a few references that were cited specifically on the slides in this presentation. Thank you again for taking the time to review this presentation.